Welcome back to Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're proud to be a community partner with Forward Radio WFMP LP 106.5. The views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. And I just want to remind folks that our pledge drive here at the station is March 27th through April the 9th. We'll have special gifts for donors. Check it out. Go to forwardradio.org. We're celebrating our birthday 4 years ago. We flipped the switch to go on the air. So please support the shows, both local and national. And again, go to forwardradio.org. Also, Monday, April the 5th at 2 p.m., Single Payer Radio will broadcast live for a special show for the station's 4-year birthday and membership drive. Listeners will hear from a variety of single-payer advocates during the broadcast. Mark your calendar, party time, Monday, April the 5th at 2 p.m. And I also want to thank the Louisville chapter of the Fellowship of Reconciliation, who agreed to take this project on probably about 8 years ago. Chris, Everett, thanks so much. And to the late Tim Sheldorf. Tim was a tremendous workhorse to get Forward Radio on the air. Thanks, FOR, and WFMP LP 106.5 is now its own 501c3 nonprofit. Here in the studio today, Doctors Mike Flynn and Eugene Shively. Guys, welcome.
Mark, good to be back again. Gene, good to see you.
It's good to see you.
Gene's looking good, dressed up there in this country suit.
And Mark, here we are, bare-chested.
Well, this is part 3 of a series of discussions that we've had over the last 2 previous shows about the overload of administrators in American healthcare. The first one, we addressed the issue of pharmacy benefit managers. The second one, we talked about for-profit health insurance companies, and today the details of the topic for conversation will be investor-owned health facilities. But I'd like to. Since we don't know whoever's listening that might not have heard the other programs, I'd like to at least set the table a little bit by making a few comments about this issue of administrative overload, and then ask Gene to talk about some of his investigations into the finances, so someone listening who might not have listened before will understand why we're doing this. So let me begin. Let me tell a story which is going to sound a little off the wall, but maybe when I get finished with it, it'll make sense. In the early 1968, I spent some months in a hospital in Vietnam, down in the Mekong Delta, treating the civilian casualties of the war. And one of my first patient encounters was an individual who has sustained a shrapnel wound to the abdomen. When an explosive device explodes, whether it's a hand grenade, a landmine, a bomb, or a rocket, the metal casing around the explosive materials fragments into a bunch of small metal pieces that fly around and do a lot of damage to the body. And in this case, one of those metal fragments had perforated through the abdominal wall and had done some damage internally. Put the patient to sleep, and I, as Gene knows, made a long midline incision. I put my hand into the abdomen and had what could only be described as a holy you-know-what moment. And Mark, I'm not going to say the word so that you don't cut me off or I get into trouble.
I really appreciate that, Gene.
Okay.
Or Mike.
So, and I could feel something sort of moving around in the peritoneal cavity. And after a bit of exploration, my hand came out with an 8-inch ascaris, a tapeworm, wrapped around my finger. And throughout the time I was there and other abdominal procedures that I had done, I realized that a large proportion of the population of Vietnam at that time had parasites. Their intestinal tract, their small intestine was filled with these worms. So if you eat some food and it goes into your stomach and it's digested in your stomach and duodenum, that then passes into your small intestine where it is then absorbed, and the nutrients go to give your muscle energy to move and build muscle mass and do all the things that the body needs. If you have a bunch of parasites in there, they will suck up that nutritional materials, and it doesn't go to your body. And I know this is a long-winded way to get around to describing why we're here, because we, in healthcare in this country, we have a huge parasitic infestation of bean counters, administrators, managers, bureaucrats, whatever you want to call them, in healthcare. I just want to make one more comment about that, and I'm going to ask Gene to get into the finances of it. So, since the mid-1980s until the late 2010s, and this is based upon 3 information sources. A New York Times article in the business section on the 9th of June, 2019, the Bureau of Labor Statistics, and Harvard Business Review. They all basically indicate the same range of numbers between the mid-1970s and the late 2010s. There's been an astonishing over 2,000% increase in the administrators, bean counters, managers in healthcare in this country. This coincides with the rise of all of the for-profit health issues that we've been talking about for the last year. So the question is, who are these people? Where are they? Who are they? What do they do? They do not work on COVID wards or COVID floors. They don't work in ICUs. They don't work in the emergency rooms. And they don't do COVID testing, and they don't give vaccinations. And that's the purpose of our conversation today. We've talked about 2 examples already, and today we're going to discuss what I think is the most worrisome of all 3. Gene, you have done some really interesting investigations into the finances of healthcare. How much is the amount of revenue in healthcare in this country, where the money goes, and how much of it is not used for healthcare? So you want to spend some time discussing that before we get into the details of the investor-owned health facilities?
Well, first, let me just say a disclaimer that what I say doesn't represent Taylor Regional Hospital, nor the University of Louisville or the Department of Surgery. I first got interested in this by looking at the total amount of money spent in the United States, which is approximately $3.6 trillion. And it represents approximately a fifth of the entire GNP of our entire budget. And the interesting part is that approximately a third of that, $1.2 trillion, has really nothing to do with healthcare. For example, we have more administrative care and money spent than any country in the world. It represents about 30% of the wasted money. We have lots more administrators than any country in the world, and sometimes we don't know what they do. Sometimes they are spending time with IT and electronic medical records. We've created an extremely complicated reimbursement system. Each insurance company's got their own reimbursement system. Everybody requires different forms for different procedures, and sometimes they reject that. Sometimes we got to get pre-authorization. Different insurance companies require different types of pre-authorization. The United States is responsible for half of the entire drug bill of the entire world. And where does that money go? Well, it goes mainly for profits, and it's not just the drug companies. Don't get me wrong, the drug companies have done some incredible things in the last few years, just in the current endemic, developing vaccines as rapidly as they have. They've set all types of records, and so they've done a good job. They've developed monoclonal antibodies. They've developed immunotherapy for cancer, and some really miracle drugs. But a lot of that money is being wasted. For example, pharmacy benefit managers. These are in-between people who bargain with the drug companies and the pharmaceutical companies, and they go back and forth. And if you're really interested in this, the next time you buy some drugs, go to different pharmacies and see if the different costs you have to pay. It's really amazing. Sometimes it can be over $100. And you can also get some idea of going to GoodRx. Is to say you've got an expensive drug and you look it up on GoodRx, there can be unbelievable difference. And why is there so much difference? It's the same drug. Well, it's mainly because the pharmacy benefit managers have bid out the drugs to the pharmaceutical companies. From the pharmaceutical companies to the drugstores, like they have a separate bid at Kroger, separate bid at CVS, separate bid at Walgreens, and so they have a different price at different places, and there's all types of rebates. There are even situations where if you pay cash, you can get the drug a lot cheaper than if you use your insurance. Sometimes if you use your insurance and deductible, the pharmacy benefit managers and the pharmacy actually makes more money. Sometimes they make less. And this is all in silos. Nobody really knows how much people are making. There's all types of equity companies getting involved in healthcare. This is accelerating. They're buying up practices. They're controlling practices. They're controlling nursing homes just in South Central Kentucky alone, where I'm from, Campbellsville, Kentucky. Most of the nursing homes are being bought up by equity companies. Now, what does that mean? We've got a for-profit company that's buying a nursing home and running it, so most of the patients in there are Medicare, Medicaid. How are they going to make money? Well, they have to decrease the cost because Medicare and Medicaid is not going to start paying them more. But this is becoming a trend. Hospitals are being bought up. Even for-profit hospitals are being bought up by equity companies. For example, LifePoint, which is a large company which controls a lot of rural hospitals in various states, have recently been bought up by Apollo, which is an equity company. We have supply companies that are being bought up by equity companies, and most of the time you don't even realize that they've been bought up. They maintain their name, they don't tell the customer, and so what you're paying for equipment, probably 10% of that money is going to an equity company. Equity companies have investors. These investors may be private investors, or they could be a retirement income fund for school teachers in California. But they're going for not just for medical companies and for sick folks. They're going for other reasons and for profit. We can go on and on and on about how private industry and Wall Street is getting more and more involved in our healthcare system. We're the only system in the world where this happens.
Gene, I thought Lifebuoy was a soap. I think that my mother washed my mouth out with it when I was saying some of the words that Mark gets asked about.
I don't believe you said any of those words when you were a
kid. You'd be surprised. Listen, one of the things I neglected to do, Gene, remind me, is to make the usual disclaimer that whatever comments I make here are my own and do not represent the views of the Department of Surgery or the University of Louisville. The fundamental issue here is that, and you're right, this is something that only exists in this country. Healthcare in this country is considered a commodity or a product, something to be exploited by for-profit entities, whereas in the rest of the world, the other 30-plus first-world countries consider healthcare a fundamental, an essential public service and a government responsibility. All of these other countries have put together systems which are similar but different, and we've talked about this before on this program. But the fundamental goal, or the basic goal, is that all of their citizens have access to good health care. In this country, we have somewhere in the neighborhood of 90 million people who are either uninsured or underinsured and vulnerable to medical bankruptcy. This is an issue that really doesn't exist in the other first world countries. I wrote an article about this, and I've said this before on one of these programs for Louisville Medicine, and when I was doing the research for it, I really couldn't find anything about medical bankruptcy in other countries. I finally found an article that indicated that there was one medical bankruptcy in the country of France, 70 million people in 2017. So all of these issues are based upon this idea that healthcare is a commodity like groceries or gasoline, and is vulnerable to all of this exploitation. Now we have some non-profit entities providing healthcare in this country. They've got the Public Health Service, we've got the Veterans Administration system, which is not a perfect system, but it seems to work very well and provides eligible veterans good care. And it's kind of like the National Health Service in Britain. They have hospitals, they have pharmacies, they have outpatient clinics. And the branches of the military service, in a similar way, have their own healthcare systems, which is also a non-profit system. It simply provides healthcare for service members, for retired personnel, and for politicians, because I know that John McCain had some skin lesions removed at the Naval Medical Center in Bethesda. I know Mitch McConnell has had some things done there. Ronald Reagan had his colon cancer removed at the Naval Medical Center. And the last president, Donald Trump, when he got on the elevator, I'm sorry.
You were hoping.
When he got on the helicopter to go to a flagship military hospital in Washington, D.C. To get treated, and none of these people pay for anything. I spent 20 years in the Navy as a medical officer, and and if you are an administrator in the Navy, you are a medical service corps officer. And based upon an Institute of Defense Analysis report from 2014, there are more medical corps officers than there are medical service corps officers in the Navy, and I'm fairly certain the same is true for the Army and the Air Force healthcare systems. In this country, in our medical healthcare, we don't really have a system, but in our medical healthcare process, there are 10 administrators to every practicing physician. So before we get into the specifics or the details of the different investor-owned health facilities, Gene, let me pass this over to you to make whatever comments you'd like to make.
But let me just add one other nonprofit that's so important to many folks in our community and our country. It's the community health centers around the country.
Well, the whole issue of just providing health care, as opposed to the conflict of interest between providing health care and using health care as a vehicle to profit, is basically the reason that we've been having all these programs.
Yeah, and the rural health care centers provide outstanding care and for people who can't afford it. Well, what's really disturbing to me is in the last year, the private equity companies are taking advantage of the COVID epidemic. A lot of physicians are having less patients because patients are afraid to come into office, afraid that they might catch COVID, and so the equity companies are taking advantage of that. They're going in and buying private practices. You may have noticed that there are not very many doctors who are practicing solo on their own or even in small groups. So the companies go in, they offer a large buy-in to the practice. They give about 20-30% of the stock in the equity company to the physicians, and then they buy the buildings, the people who work for them, the supplies, and they can decrease the cost of the supplies by buying in bulk, and they can also compete with the insurance companies because eventually they will control the market. For example, in dermatology, they'll go in and buy one group, then they'll buy other individual dermatologists, and before long they've got a monopoly, and so they can increase the price that the insurance companies make. And then they start squeezing the dermatologists. Now, in most states, it's against the law for a separate entity, a non-medical practice, to own a company like that, but they keep the ownership in the hands of the doctor. But the private equity company owns the rest, and then they start pressuring the doctor to do things to make more money, do more biopsies, do more procedures, and eventually, after 4 or 5 years, they may have borrowed some money. They made a profit, and they turn around. And this is common regardless of whether they're in medicine or not. Equity companies usually buy companies that are borderline. They work with them, and then they turn around and sell them for a profit. And they're doing the same thing in medicine. The same thing's going on in several large urology practices. And I was surprised to find out that about about a third of the ER practices in the United States is owned by equity companies. So you've got another factor involved when you go and see one of these doctors. The doctors, I'm sure, are trying to do the right thing, but they've got some pressure on them to try to make more money. And I don't think it's ethical or moral to get profit involved in taking care of sick folks. Just think about if your grandmother is in the nursing home and she's had a stroke, why should 10% of the amount of money that's being paid for her to be there go to a for-profit company? No one else does that, and we haven't done it in the past. It's only since the 70s and 80s have we evolved into a for-profit industry, and healthcare is now an industry in this country.
Yeah, let's let's talk about investor-owned medical practices. And before we do that, I don't know if you all remember, it was an earlier program. We at the end of the program, we raised this rhetorical question. I think we were talking about for-profit health insurance companies and how much money they were sucking out of the system, and that the money that simply goes in the door as premiums that people pay with the expectation of getting health care. But the question we raised was, well, as bad as it is, can it get any worse? And the answer to the question was yes, and it's already happening, and that's what we're talking about today, is the investor-owned health care facilities. So medical practice groups. I'm going to talk about some things that have come from two reference sources, a JAMA, J-A-M-A, Journal of American Medical Association article on 18 February 2020, and the Bloomberg Business Week article from 20 May 2020. And I would make another comment before getting into the details, and I think it's important for anyone listening, is not to take anything that any of the three of us say at its face value, but hopefully that whatever we say will maybe give them something to think about. And I would encourage them to go to whatever other information source they consider is reliable or important and double check what we're saying. Don't believe us. We're not making this stuff up, but go check it out yourselves. So let's get into the private equity-owned physician medical groups. A number of issues there, as Gene has already alluded to. Most of these companies expect a return on investment of somewhere in the average of around 20%, whether in the first 2, 3, or 4 years. Their explanation, or their what I would call their shtick about the benefit of having an equity owner or manager or partner is that they claim that they will make the practice, quote, more efficient. Now, more efficient for a hedge fund operator means that they make more money out of it. More efficient for a healthcare provider means that they provide better health care, and this represents a fundamental conflict of interest. So, as Gene mentioned, they usually let's just assume you're buying into a practice, and one of the first things that usually comes along when the new recruits are brought on board, there's a non-disclosure agreement. So nobody, well, not just with the new recruits, but nobody knows exactly what's going on because all of the partners have had to sign the non-disclosure agreement. Both of these articles suggested that most of these exchange or changes in the investor-owned health medical practices are occurring in the South. Anesthesia, the emergency room, family practice tend to be the top four. I had some personal experience with a investor-owned anesthesia group at a Louisville hospital where I practiced before I retired. And I retired about 2 years ago, and this was about 2 years before that. And the anesthesia group, which had been there for 20 some odd years, and from my standpoint, were really good because as a head and neck surgeon, having a group that could do difficult intubations was really important. And the anesthesia group and the hospital couldn't come to agreement about their future relationship. And to be fair, I think the hospital had some pretty reasonable requests, and the anesthesia group was being a bit recalcitrant. But that's another issue. Hospital management, the hospital finally decided that they ended their relationship, and they hired an investor-owned group from Texas. And I'm going to read a letter that I sent to the medical director, who has happened to be the chief of anesthesiology, which was sent about 6 months after they came on board. And I sent copies of this letter to the CEO of the company and everybody else that I could send it to, including the chairman of the Department of Surgery. And so I'm just going to read the second paragraph, and I'm going to leave the names out and the dates. The arrival of this company at this time was a worrisome event. This began with the introduction of a revolving door of locum anesthesiologists, many ranging from professionally mediocre to marginal competence to incompetent. At a recent Louisville Surgical Society meeting, one of the surgical residents reminded me of an incident where a tooth was knocked out during a routine intubation of one of my patients, and the anesthesiologist attempted to replace it into the socket after I had left the operating room to talk with the patient's family. Also, had indicated in the letter that that gentleman that I had sent, the physician who was chief of anesthesiology, who I had sent a letter to, indicated to me that they were hiring a group of cardiac anesthesiologists, and this was a hospital that did some cardiac surgery, but it really wasn't what I would consider a major aspect of their medical care. And I raised the question of how proficient cardiac anesthesiologists were in doing difficult intubation, because there were at least 6 surgeons doing head and neck surgery or endocrine surgery where the ability to do difficult intubation was an important part of the process. So I don't know how things are going now. This really didn't start out very well. Let me just mention a few more issues related to how a practice changes when it becomes investor owned or investor managed, and then I'm going to pass this back to Gene again for his thoughts. Again, annualized return on investment over 2 or 3 years. The first thing that happened in this large dermatology practice in California was a discussion about how the decision process would change, and it was indicated that the medical decision making would have changed so that there would be some influence by the investor group in the medical decision making, which, when you think about it, is really kind of interesting. And in the example of this, was kind of going to be like a marriage, where two people would get together and decide what was the best thing to do. The other issue was after, as Gene had mentioned earlier, after the acquisition, they bought supplies, and in bulk, they encouraged recruitment of new physicians, and all of these new physicians would come on board with non-compete agreements. They established a scorecard with daily and monthly or periodic financial goals. There was procedures were encouraged. There was a bonus program. They encouraged revenue-raising procedures, doing biopsies, Botox, and Mohs. So everybody coming into a dermatology practice really doesn't need a biopsy unless the managers are encouraging, biopsies to be done. The medical assistants were again encouraged to check more boxes on the physical examination form, often indicating that more areas were examined than the dermatologist had actually examined, which actually is a form of healthcare fraud when you get down to it. And then some of the other issues, the biopsies or the excisions were sent to pathologists who either were also owned or managed by the investor group or had some relationship. So wherever the pathology was being sent for analysis, this often changed, and the pathology was sent to some other place. And anyone who does any kind of surgery that involves tumor or tissue knows the importance of having a pathologist who's good at surgical pathology as opposed to laboratory medicine or some other things. Last example before I pass this over to Gene was the purchase of supplies from either another investor-owned company or a company with a relationship with the investor owners or the investor managers. And one of the worrisome examples of this was the quality of the supplies, at least in this one case, really didn't match up to the quality of the supplies that they had gotten before this investor group took over this large dermatology practice. And just one example was the needles. If you have a needle, there's a little plastic tip on the needle where you insert it into the syringe, and then the needle sticks out the other end. And for a period of time, they had acquired a number of really poor quality needles, where the needle actually broke off during the injection, and so that the dermatologist either had to pull it out or they had to dig around in the skin to get the needle out. Again, these are just a number of examples of this fundamental conflict of interest between just simply the ability to provide health care and an assortment of ways that an investor-owned company looks at finding different methods or steps to extract more profit out of a practice. Gene, your thoughts?
Other companies are getting into healthcare. For example, Amazon is recently moved into several states with healthcare, where they're going to provide healthcare for their employees, and then I think they're going to advance that. Kentucky's one of those states. Walmart's getting into healthcare. Of course, Humana started out as a healthcare company right here in Louisville. They became an insurance company, but now they're getting back in to clinics. And we even got Silicon Valley getting into healthcare with telemedicine. We have for-profit companies working for for-profit companies, providing wellness exams, other for-profit companies getting more and more involved. Now, one of the things we haven't talked about on these programs is fraud, and we don't know exactly how much is that represents. It's estimated to be about $100 billion. It's probably more than that. It probably represents 10 to 12% of the money spent. And so there's all different types of fraud. The federal government usually only goes after stuff that's very obvious. For example, people billing for procedures they didn't do. But there's other types of fraud that's very difficult to detect. For example, billing services that were not done, upcoding services. For example, there are different codes for different visits. There are different codes for different types of procedures, and it's easy to upcode these procedures. Duplicate claims, excessive services, unnecessary services, kickbacks. If, for example, if you pay another doctor to refer patients to you, and another entity, which I'm not exactly sure how it works, but copying, pasting entities on electronic medical records. One of the things that's being done, again, which I'm not a computer expert, is that the way bills are sent out on the internet, the government looks for correctness, and if you've got everything spelled correctly and put in correctly, then they go ahead and pay the bill. But it's very hard to detect if something's upcoded. That would require an extensive procedure, so they go ahead and pay it. Apparently, there's a lot of fraud along those lines. A lot of this is borderline. It depends how you define it. But there's a lot of that going on. Most of the big fish are getting caught, but it only represents a small amount of the total. It's probably maybe the government may be catching 10% of it. So more examples of a huge amount of money that's being wasted on health care that should be going to patient care. And let me talk about one other thing. I've had several questions by friends say, why are you so interested in this? Why can't you just use this as a vehicle for helping your doctor friends or the hospital get money. They get it through the equity company. Well, because it's for profit, and we are, at least traditionally, have been a profession, and a profession is a group of people. Traditionally, has been law, the clergy, and medicine, where we provide services for people regardless of their ability to pay. And that's different than selling a car or a diamond ring. You know, you expect to make money on that, but providing medical services is to help people, and regardless of their ability to pay. For example, if I get called to the emergency room at midnight with somebody who's got a appendicitis, then my job is to take their appendix out. It's not my job to say, well, this is going to cost you $1,000, and if you don't pay, I'm not going to take care of you. That's a real professional, and we need to get back to that.
I agree with you, Gene, and that's kind of why we've spent as much time as we have in here driving Mark nuts talking about these things. All right, I'd like to get back into the some of the specifics of these investor-owned healthcare facilities and talk about nursing homes, because this is, at least in my opinion, the worst of the worst example, because in this situation, some of the most vulnerable in our population are being exploited. And again, the reference source for this is the 14th of March of this year, New York Times, a front page article, and and this was this very specific. There were it names names, places, facilities all over the country. And the basis of the reporting, again, was multiple sources. So there were a long list of examples of poor performance and neglect, mostly related to staffing in these investor-owned nursing homes. One example is the frequency of a bed sore or decubitus ulcer. So if you put your hand on your lower back and you feel the hardness of your pelvis, depending upon how much weight you carry, you could have an inch or 2 or 3 of skin and fatty tissue over that. And if that individual lies in bed and doesn't get moved, the skin and the fatty tissue under it will die, and it creates an ulcer. And this is called a decubitus ulcer or a bed sore. These individuals frequently wear diapers. And as you know, if a diaper isn't changed on a regular basis, it fills with fecal material, and often these decubitus ulcers or bed sores are contaminated with fecal material. And there were a number of references to this in this article. Another example was this poor woman was put on the toilet, and then she was left by the staff, and in an attempt to get off and clean herself, she fell and broke her ankle. Again, I'm going through a list of hair-raising experiences. Everyone in a nursing home, isn't there sort of waiting to depart the earth. There are some people in nursing homes that are recovering from trauma, from accidents, and in this one case, there was a surgical infection, which when they took the dressing off, there were maggots in the wound. There are multiple examples of patients or residents in these assisted care facility and nursing homes that were over medicated to keep them passive. Their falls from chairs. The high infection and death rates related to COVID are often due to staffing issues. All of the issues of the decubiti are often related to the staff, inadequate staff to get her in there and turn patients, get them out of bed and make them walk. Another example was, and this was a nursing home somewhere up in the Northeast, where the residents were awakened at 3 or 4 o'clock in the morning to be fed, and then they were left for hours until their next meal. And again, all this has to do with staffing and the explanation of how things are improved if a nursing home is run by an investor-owned company is that they, quote, make it more efficient. And as I said earlier, the more efficient aspect of the for-profit entity is a way to make more money out of the nursing home, which generally involves decreasing the simplest and quickest way is to reduce staffing. And what's more efficient from a healthcare provider is providing better health care or better care. Mark says there's 5 more minutes. Gene, as we finish this up, I would like you had made some mention either in the last program or the program before about the experience that the surgeon from Boston, Atul Gawande, had in doing some work with, I think, was it Amazon? I can't remember the other companies, and what they decided after they eventually disbanded the activity that they had.
Well, as you may remember, this was in the news about 2.5 years ago. Berkshire, Amazon, and J.P. Morgan decided that they were going to form their own healthcare company, and they hired the surgeon who's fairly famous and had a lot of experience with writing and healthcare management to try to set up a company that they would better do their health care for their employees. So here we have 3 of the best companies in America, and they were a failure. They couldn't get it to work. And I was really interested and one of the statements that he made when he stepped down as CEO is that he did not think that the healthcare in America could be fixed without government intervention. Now, that doesn't mean that the government has to completely take over. There are a lot of people who are extremely opposed to that. I don't think it would pass Congress right now. I myself has been accused of being a socialist. I don't think I'm a socialist. I've been to Cuba. I've been to China.
What did you read? Did you read Mitch McConnell's the editorial page a couple of days in the Courier Journal?
Yeah, I did read that.
Well, he's keeping us from marching the healthcare march to socialism. Well, I agree with you, and this is the reason I wanted you to do that, because I think it's the recognition, and it's important, that the only way that the healthcare system in this country is going to change in a fundamental and significant way is if it is done by the central government. If you just look at the energy fiasco in Texas, or some of the way Medicare has been managed in Texas and Arkansas and Mississippi and places like that, letting states pick away at these things in different ways it just that isn't it isn't going to work. This program is sponsored by Kentuckians for Single Payer, and I don't know how long it's going to take, but that's really the only way that this healthcare in this country is going to get out of the hole it's in. And we don't have to reinvent the wheel. All we have to do is look around the world. The British do it one way with a all and complete, system where they run the hospitals, they run the pharmacies, they run the physician offices. Up in Canada, they have a single payer system that covers doctor and hospital costs. You can get private health insurance in either of those countries. Taiwan has a universal healthcare system that does not allow private. There's a lot of ways to do that. But until we get to the point, I think, where we recognize this is an issue that needs to be addressed by the central government, we're going to be stumbling around in what we're stumbling around. I don't know, it's the dark or the gray or wherever we are, because it isn't going to change until that happens.
Well, one of the things that the government can do is they can just regulate the health system, like they regulate utilities, like they regulate rural electric companies, et cetera, so that profits just don't get way out of control.
It took Japan 10 years to transition from a system like ours to their universal healthcare system.
Okay, guys, another hour has flown by. Want to let our listeners know that they can tune in to Forward Radio WFMP LP 106.5 and listen live or stream us on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. And for more information about Single Payer Radio and Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org or follow us on Facebook. And also, a big thanks to the team at Forward Radio, WFMP 106.5. It's an all-volunteer station. And I want to thank Justin. Justin is the Pope of Forward Radio. The Pope Mobile has 2 wheels for Justin. And also include in that big thanks Ruth, our manager, Melissa, K.A., Tori, Carol, Dave, so many others that deal with the fundraising, paying the bills, reporting, training, all volunteers. So if you have a few bucks left from your stimulus check, think about sending a few dollars to forwardradio.org. Click on the donate button and think about becoming a sustainer. $5 or $10 a month would go a long way. It's forwardradio.org. Guys, thanks again.
See you next time.